Usually when we think about what connects completely disparate events in history, we look for some grand conspiracy or maybe a massive cultural shift. But today, I want you to picture three things.
Okay, Kyra.
First, a famous actor's newborn twins lying in a hospital in 2007. Second, a highly respected health columnist for the Boston Globe in 1994. And finally, a $327.6 million NASA spacecraft hurtling toward Mars in 1999.
Which sounds like the setup to a very strange riddle, right?
Yeah.
I mean, you have Hollywood, journalism, and literal rocket science.
Exactly. But on the surface, these three things have absolutely nothing in common, except every single one of them was the victim of a unit and measurement error.
Oh, wow.
Yeah, a simple, catastrophic failure to translate one number into another correctly, which is exactly why the math you might be sweating over in your TEAS or HESI prep books right now isn't just, an academic hurdle to clear.
Right, it's the invisible safety net of the entire medical system.
So today, we are decoding the world of dosage and measurement conversions. Welcome to the deep dive.
Because, on the surface, this looks like narrow clerical math, like a little bit of multiplication, a little bit of division.
Right, just moving numbers around.
Exactly. But it is actually the ultimate test of a clinician's critical thinking. I mean, the arithmetic itself is usually elementary. It is the high-stakes context that makes it so rigorous.
Because you are taking a theoretical number from a page and translating it into a physical substance that goes directly into a human body.
Right, exactly.
Okay, well, let's unpack this. When we say dosage and measurement conversions, we're talking about the applied arithmetic that nurses use to translate a medication order.
Which might be written in one unit or one concentration or an entirely different historical system completely.
Right, into the exact quantity a patient needs, safely and accurately. But before you can even do the math, you have to understand the units. And looking through our sources, I was struck by this massive, glaring question. Why on earth are there so many different, confusing units in medicine in the first place?
Yeah, it feels incredibly fragmented, right?
Very much so.
Well, it's fragmented because no one ever sat down and rationally designed medical math. The math is only necessary because modern medicine is essentially the site of a massive historical pileup.
A historical pileup. I like that.
Yeah, you have three entirely different historical measurement systems colliding in the exact same profession. And nurses are expected to be the real-time universal translators between all of them.
So let's start with the oldest of those three, right? The apothecary system.
Right. We're talking medieval and early modern European pharmacy here. Drams, minims, scruples.
I read that a minim was roughly the volume of a single drop of water.
Yep, exactly.
Yeah.
But the one that really stood out in the sources was the grain.
Yeah, I always assumed grain was just a generic, poetic word for a small amount, like a grain of sand.
Well, originally, the unit of a grain was literally based on the physical weight of a single dried grain of wheat.
Wait, a literal grain of wheat?
A literal grain of wheat. Back in the Middle Ages, before standardized manufactured weights, apothecaries needed a baseline that anyone could find anywhere.
So 1 grain of wheat became the foundational unit of medical mass.
Why?
Wait, I have to push back here, though. Are you telling me that a nurse walking into a hyper-modern digital ICU in the 21st century still has to do math based on medieval wheat weights?
I mean, yeah, basically.
That sounds totally obsolete.
Well, the FDA is certainly pushed to phase it out, but it survives through sheer institutional momentum. Patients still use it colloquially, and you will still see it in older drug references or specific over-the-counter medications.
Really? Like what?
The most famous survivor is aspirin. If a patient tells you they take a 5-grain aspirin, they aren't speaking in approximation.
They mean literally 5 grains.
Yes, they are citing an exact historical measurement. 5 grains is approximately 325 milligrams. So if you don't know that medieval wheat conversion, you fundamentally do not know what dose your patient is taking.
That is mind-blowing, honestly.
It is. And it shows why this translation skill is so vital.
Okay, so that's system 1. System 2 is the one we all know and mostly rely on today, which is the metric system. And this one actually does have a specific birth date. It was born directly out of the chaos of pre-revolutionary France.
Oh, absolutely. At the time, France had hundreds of regional, completely inconsistent units for a pound or a foot, depending on which province you were in.
Right, and the French Academy of Sciences and the National Assembly officially adopted the metric system in 1795 to fix that exact problem.
Because what's fascinating here is the metric system's entire promise was universality.
Just one standard for everyone.
Exactly. 1 gram, 1 liter, 1 meter, defined the exact same way everywhere on Earth using base 10 math.
which is obviously much easier to calculate.
Way easier. And medicine started shifting to metric over the next century and a half, specifically because those apothecary units, like our grains of wheat, were too inconsistent between different suppliers.
Right, because a wheat grain in one place might weigh more than one in another.
Exactly. As global trade expanded, a physical grain of wheat from one climate might weigh slightly more than a grain from another. When life and death are on the line, you simply cannot have your drug dosages varying based on agricultural differences.
So we have the medieval apothecary system, the 18th century French metric system, and then we have the third system, which is just, the American kitchen drawer.
Right. Household measurements, teaspoons, tablespoons, cups.
This is the language that patients actually speak when they are at home.
Yes, and this is where we run into a very dangerous misconception. There is an old colloquial phrase, a teaspoon is a teaspoon.
Right, like any spoon will do.
But if you look in your own kitchen drawer, the spoons vary wildly. You might have a shallow spoon for cereal, a deeper one for soup, and none of them hold the same volume.
Definitely not.
So a medical teaspoon is a precise, standardized measurement. 1 teaspoon is exactly 5 milliliters. 1 tablespoon is exactly 15 milliliters.
So you should never tell a patient to just grab a random spoon from their silverware drawer to take their cough syrup.
Never. You always use a standardized dosing cup or syringe. But as a clinician, when a parent rushes into the ER and says, I gave my toddler 2 teaspoons of Tylenol.
You have to know what that actually means.
Right. You have to speak their household language and immediately convert it back to metric, which would be 10 milliliters for the medical chart.
So a modern nurse essentially has to act as a fluent translator between medieval apothecaries, French revolutionaries, and a patient's kitchen drawer. That is a massive cognitive load.
It is a huge load.
How do they actually do that without making mistakes? Because from what I read, dosage calculations didn't really become a formal, rigorous nursing skill until the mid-20th century.
Yeah, so as hospitals centralized their pharmacies in the 20th century, the actual bedside administration remained the nurse's responsibility.
So they had to start formally teaching medication math to bridge that gap.
Exactly, between what the pharmacy sent and what the patient needed. And fundamentally, every problem a clinician faces is one of 2 things.
Okay, what's the first one?
First, it might be a unit conversion. You have the exact same substance, but a different label.
Like converting 500 milligrams into 0.5 grams.
Right, or a patient's weight from pounds into kilograms.
And the second type?
A dose calculation. That's when you use a drug's known concentration, say 50 milligrams dissolved in every 1 milliliter of liquid, to figure out the physical volume you need to drop into a syringe to meet the doctor's order.
Which brings us to the great pedagogical debate in nursing education. Because if you are prepping for a nursing exam right now, you are probably swimming in these different calculation methods.
Oh, definitely. There are a few major ones.
Like the older traditional method is ratio and proportion, right? You set up 2 equal fractions, say what you have on the left and what you need on the right, and you cross multiply.
Yeah, that's the classic way.
Then there's the desired over half formula, which is really quick. But our sources note it completely breaks down on complex, multi-step problems.
Right, this doesn't hold up. Then you have the method that was heavily dominated classroom instruction since the 1990s, which is dimensional analysis.
Also called the factor label method, right?
Yes, it was actually imported straight from chemistry, heavily popularized in nursing by textbook authors like Anna Curran.
How does it work, exactly?
Well, instead of memorizing a rigid formula, you create a sequential chain of fractions where the units cancel each other out until only the unit you want is left standing.
I was thinking about this, and the best way I can describe dimensional analysis is that it's like a grammar checker for math.
Oh, I like that comparison.
Yeah, like if you're writing a sentence and your grammar checker underlines a weird verb tense in red, you know you've messed up the structure before you even hit send. Right. With dimensional analysis, if your final sentence or your final unit doesn't make sense, the formula flags its own error.
It self-corrects, essentially.
But if I'm using dimensional analysis, how does it actually catch my mistakes in practice? Walk us through the physical mechanics of it.
Let's visualize it. In dimensional analysis, you set up a series of fractions, specifically so the unit in the numerator, the top of one fraction, matches the unit in the denominator, the bottom of the next fraction.
Okay, so top and bottom match.
Right, and when they match, you cross them out. They cancel. If you want your final answer to be in milliliters, but after canceling everything out, you are left with milligrams in your numerator, the math itself is screaming at you that you built the equation upside down.
Wow, so you just know right away.
Exactly, which is something ratio proportion simply cannot do. If you set up a ratio proportion backwards and cross-multiply, it will confidently hand you a clean, totally wrong number with no warning that you just calculated a lethal dose.
That is terrifying, honestly. Well, let's make this incredibly concrete for you listening, especially if you're gearing up for an exam, because this next scenario is a classic. Weight-based dosing.
Oh yeah, the classic exam trap.
Let's say you have a child who weighs 44 pounds, and they need a drug that is dosed at 10 milligrams per kilogram of body weight.
This is a perfect illustration of systems colliding. American parents and many American triage scales record weight in pounds.
But every medical drug reference on the planet dictates dosages based on kilograms.
Exact.
So step 1 is the trap. You cannot just multiply 44 by 10.
No, definitely not.
You have to convert pounds to kilograms. The magic number to memorize is 2.2. So you take the 44 pounds, divide by 2.2 pounds per kilogram, and you get 20 kilograms.
And that is your unit conversion.
Right. Then step 2 is the dose calculation. You take that 20 kilograms, multiply it by the ordered 10 milligrams per kilogram, and you get your final answer of 200 milligrams.
Yep. If we connect this to the bigger picture, missing or fumbling that specific 2.2 pound a kilogram step is a leading cause of pediatric dosing errors.
Because if you skip the translation and just multiply the 44 pounds by 10, you calculate a dose of 440 milligrams.
Right, you have more than doubled the intended dose for a child purely because you treated a pound like a kilogram.
So what actually happens when that math goes catastrophically wrong? Because units aren't just bookkeeping on a patient's chart. They are the physical reality of the treatment.
They absolutely are.
Let's circle back to that hook from the beginning, starting with the NASA Mars Climate Orbiter in 1999.
Oh, right. The orbiter. That was a $327.6 million piece of technology. It traveled millions of miles to Mars, and as it went to enter orbit, it just burned up in the Martian atmosphere.
Because of a unit error, right.
Exactly. The investigation revealed that one engineering team was calculating thrust using metric Newton seconds, while the other team was using American pound force.
Wow, so an unreconciled unit mismatch literally destroyed $1/3 billion.
Yeah, it proves that an equation can be mathematically flawless, but if the units don't align, the result is destruction. And while NASA lost a machine, in medicine, unit errors cost human lives.
Right. Which brings us to Betsy Lehman, the highly respected Boston Globe health columnist.
Yes, a truly tragic case.
In 1994, she was being treated for breast cancer at the Dana-Farber Cancer Institute. She died because of a horrific chemotherapy protocol error.
That's right.
She received 4 times the intended dose of a drug called cyclophosphamide. How does a math error physically get that big?
Well, it was a devastating translation error regarding time and volume. Her chemotherapy protocol called for a specific total dose to be spread out safely over 4 days.
Okay, so over 4 days.
But the order was misinterpreted, and the total 4-day dose was administered as her daily dose.
Oh my gosh, all at once.
Well, in one day, yes. Cyclophosphamide is highly toxic. It works by damaging the DNA of rapidly dividing cancer cells.
Right, as chemotherapy does.
But in a massive overdose, that toxicity destroys healthy tissue. In Lehman's case, it caused severe cardiotoxicity, which is massive damage to her heart muscle.
The medical community was shaken to its core by that, understandably.
It was a massive wake-up call. Her case became one of the primary drivers behind the Institute of Medicine's landmark 1999 report, To Err is Human.
Right. That report publicly revealed that tens of thousands of Americans were dying annually from preventable medical errors.
And medication calculation mistakes were sitting right at the top of that list.
Here's where it gets really interesting, though. Sometimes the underlying arithmetic is actually perfect, but the patient still gets a massive overdose.
Yeah, that's a whole different kind of trap.
Which is what happened with actor Dennis Quaid's newborn twins at Cedars-Sinai in 2007. They were given a devastating heparin overdose, but the nurses didn't necessarily do the multiplication wrong.
Right. The Quaid case was a concentration error.
Walk us through that.
The infants were prescribed a flush of infant-strength heparin, which is 10 units per milliliter. Instead, the clinicians accidentally grabbed vials of adult-strength heparin, which is 10,000 units per milliliter.
Wow, 10 versus 10,000.
Huge difference. The physical vials looked almost identical and were stored in the same automated dispensing cabinet. The nurses drew up the correct volume of liquid. They did the math correctly for the volume.
But because it was the wrong concentration, they delivered a 1,000-fold overdose.
Exactly. Getting the math right on the wrong vial is just as deadly.
Let's clarify something crucial for you listening, because the term units was just used. 10 units per milliliter. There is a massive misconception that units like insulin units or heparin units are just another way of saying milligrams or
Oh
micrograms.
yeah, that's a very dangerous assumption. A unit in pharmacology does not measure physical mass. It measures biological activity.
Biological activity, what does that mean in practice?
It answers the question of how much of this specific drug is required to produce a specific biological effect in the body. Heparin, for example, is an anticoagulant. It prevents clots by binding to a protein in the blood called antithrombin III.
So a unit of heparin is defined by how effectively it prolongs blood clotting time.
Exactly. So the conversion between units and milliliters depends entirely on the concentration printed on that exact vial.
So U100 insulin means there are 100 units of biological activity in every milliliter.
And U500 means there are 500 units in that same single milliliter. If you treat those two vials as interchangeable, just because they both say insulin, the biological results are fatal.
So biochemically, what happens when an infant gets a 1,000-fold overdose of heparin? This ties directly into the concept of the therapeutic index, right?
Yes, exactly. The therapeutic index is the margin between a dose that is effective and a dose that is toxic.
Okay, so consider a drug like amoxicillin.
Right, amoxicillin has a wide therapeutic index. If you accidentally take double the dose, you might get an upset stomach, but you generally aren't in lethal danger.
But heparin is different.
Very different. Heparin, digoxin, insulin, warfarin, these have incredibly narrow therapeutic indices. They leave zero room for calculation errors.
So when those infants received 10,000 units and so 10, their blood fundamentally lost the ability to coagulate.
Exactly. A narrow therapeutic index means a slight unit mistake doesn't just make the drug less effective, it makes it instantly actively lethal.
Because these errors were so common and so deadly, the medical field realized they couldn't just stand around and yell at nurses to, quote, do the math better, end quote.
No, they actually had to change the fundamental rules of how numbers themselves are written down on a chart.
Right, they had to account for the physical reality of a hospital. You have a doctor scribbling an order under fluorescent lights and a fatigued nurse trying to read that handwriting at 3 in the morning.
Exactly. This led to institutional rule changes championing systemic safety.
Led by groups like the Institute for Safe Medication Practices, or ISMP, founded by Michael Cohen in 1994, along with the Joint Commission.
Right, they created what is known as the Do Not Use abbreviation list.
And if you are taking a nursing exam right now, you will absolutely be tested on this list. Let's go through the big ones. First, trailing zeros. You are taught to never write 1.0 milligrams. Why is that?
Because if the decimal point is faint, or written too lightly on a paper chart, or simply missed by a tired reader, 1.0 milligrams is instantly read as 10 milligrams.
So you have just created a 10-fold overdose out of thin air.
Exactly. You must simply write 1 milligram.
Conversely, leading zeros. You must always write 0.1 milligrams. You can never just write 0.1.
For the exact same optical reason.
Right.
Without that leading zero physically drawing your eye to the decimal point, 0.1 looks exactly like 1.
Another 10-fold error.
Right.
And finally, abbreviating the word units as just a capital U.
Never do it. A handwritten U can easily loop and look like a 0.
So if you quickly scribble 6U for 6 units of insulin, the next person picks up the chart and reads it as 60.
Yep, 60 units.
Wow. So what does this all mean for you listening? It means that when your instructors or your textbooks are grading you harshly for missing a leading zero, they aren't just being nitpicky grammar police.
No, these are blood-written laws.
They are direct institutional responses to documented catastrophic overdoses.
It perfectly illustrates the concept of the rights of medication administration. Right patient, right drug, right route, right time. Dosage calculation is the highly specialized tool the clinician uses to verify the right dose.
We have covered a massive amount of ground today on this deep dive, from medieval grains of wheat to the Mars orbiter, all to explain why you have to multiply by 2.2.
It's a lot to take in.
So when you were sitting at that exam terminal or standing at a patient's bedside, just remember a few core takeaways.
Right. Number 1, always convert to the same unit before you even start calculating, because mixing up pounds and kilograms is the number 1 trap.
Number 2, rely on dimensional analysis because it is your self-checking safety net. If your final unit is wrong, your math was wrong.
Number 3, remember that a biological unit is measuring the drug's activity, not the physical volume of liquid in the vial.
Number 4, lock in those key conversions. 1 kilogram is 2.2 pounds, a standardized teaspoon is 5 milliliters, and a grain is about 60 milligrams.
And finally, never trust a trailing zero and never omit a leading zero.
Those principles will carry you through the vast majority of safety and calculation questions you will ever face. But before we wrap up, let's look toward the future,
Yeah, I want to leave you with one final thought to ponder, especially as we look toward the future of healthcare.
where hospitals are increasingly relying on automated smart pumps, AI-driven prescribing, and electronic safeguards.
Right, which is wonderful for safety. It does a lot of this conversion math automatically. But it raises a critical question. What happens to the human sanity check?
Oh, that is a fascinating point.
If future clinicians stop practicing this math by hand, do we risk losing the fundamental cognitive instinct to look at a machine's perfectly calculated number and instantly realize that it is clinically absurd for the patient sitting right in front of us?
That is a chilling thought. You can have the most advanced AI in the world, but if the human stops being the ultimate grammar checker for reality, we are right back to the Mars orbiter burning up in the atmosphere.
Exactly. The tech doesn't replace the need to understand the units. The human mind is, and always will be, the final safeguard.
Well, on that note, thank you so much for joining us for this deep dive. Whether you're heading into an exam or just navigating the healthcare system for yourself, stay curious, trust your instincts, and always check your units. We'll catch you next time.